Committee on Health and Human Services Finance will come to order. Representative Schumacher moves approval of the minutes from April 16th, 2018. Do I have any corrections or additions? Seeing none, all those in favor of adoption of the minutes from April 16th, 2018, please say aye. Aye. Those opposed, no. The minutes are adopted. First up, members, and our only business of the day will be the 3138 walkthrough and public testimony. So thank you for the people who came today and signed up to testify. And if you have not signed up yet and you are here to testify, if you could check in with the pages, that would be greatly appreciated. We're going to do a quick walkthrough of the bill with the research staff, and then we're going to go right to public testimony. We may do part of the walkthrough tomorrow with Ms. Clark-Best in certain sections. But if the researchers could just start off with two, Randy, if you want to start off with two, and then without coming back to the chair, if we could just walk through them, if you guys could just kind of follow along Sunday school style, that'd be great.
Sure. Mr. Chair and members, Article 2 is the healthcare article, and that begins on page 67 of the Delete Everything Amendment. Section 1 it's a modified version of language in House File 3132. This would allow the Department of Public Safety to provide last four digits of Social Security numbers to DHS for purposes of recovery of Minnesota healthcare benefits. Section 2 is from House File 2725. This would require the DHS, when using unexpended balances in their technology accounts, to first obtain a review from the Legislative Advisory Commission. Section 3 is from House File 2919, dealing with telemedicine services. This adds community paramedics to the list of providers that can provide telemedicine services, and it provides an exemption from the limit on coverage of 3 telemedicine services per enrollee per week if the services are for the treatment of tuberculosis. Section 4 is from House File 1269, dealing with federally qualified health centers. The language on the bottom of page 72 would allow FQHCs to submit their claims directly to DHS for payment, and right now they submit them through the managed care plan. Section 5, also from House File 1269, it requires DHS to report on a process to allow FQHCs to obtain 340B drug discounts and to avoid duplicate discounts. Section 6, this is House File 2761. This is the language that requires DHS to reconcile Minnesota Care premiums. There was an amendment added that prohibits DHS from using agency staff or resources to offer a product similar to Minnesota Care, and there's some financial penalty language. Section 7 is from House File 3132. It directs DHS to contract with the vendor to implement the third-party liability recovery program. This is the modification of language that was in the actual bill. Section 8, this is House File 3198. This section requests the legislative auditor to study rate disparities or geographic rate disparities in the individual and small group markets.
All right, Mr. Chair and members, Article 3 is the chemical and mental health article. Section 1 is from House File 1331, and it specifies how data collected by a sheriff or corrections agency for individuals who may have a mental illness it specifies how the data is treated. Sections 2 through 7 are from House File 3455, and this was one of the amendments that was recently added. Section 2 allows the Commissioner of Human Services to issue a temporary change of ownership license or provisional license in certain circumstances. Section 3 requires a license holder to notify the Commissioner of Human Services and obtain approval before making any changes that would alter the license information, and also lays out some requirements related to the notification. Section 4 lays out requirements for a license application after a change of ownership. Subdivision 1 specifies that a license is not transferable or assignable. Subdivision 2 requires the submission of a new license application when a change of ownership will occur, and specifies what constitutes a change in ownership. Subdivision 3 lays out the requirements for when a change of ownership occurs. And Subdivision 4 establishes a temporary change of ownership license for a new owner or operator while the Commissioner evaluates the license application. Section 5 is also from House File 3455 as amended. It requires the Commissioner to set aside a disqualification for an individual in the chemical dependency field who's a nonviolent controlled substance offender and who has successfully completed treatment and has abstained from controlled substances for at least a year. Section 6 relates to the set-aside in Section 5. Section 7 is also from House File 3455, and it specifies that the assessment of need process that is currently in Minnesota rules does not apply to programs, substance use disorder programs licensed under Chapter 245G. But it does allow the Commissioner to deny a license if the services in the local area are sufficient to meet local need, and new services would be detrimental to those in the area. Section 8 is new language that removes language governing the transfer of funds from the Chemical Dependency Fund for specific administrative purposes. Section 9 is also from House File 3455 as amended. It removes a provision requiring prior approval from the Commissioner for chemical dependency services, but again allows the Commissioner to deny a license under certain circumstances. Section 10 is from House File 3455 as amended, and the original language was from House File 4307. It updates terminology related to the post-arrest community-based service coordination for individuals with mental illness or substance use disorder, and adds language including Indian Health Service facilities, and adds two types of service providers who may provide this care coordination. Section 11 is from House File 1331. It allows a sheriff or local corrections staff to share certain mental health data and other private data on inmates, and to refer an offender to the local county social services agency to arrange for listed services. Sections 12, 13, and 14 are all from House File 3134, I believe the first engrossment. Sections 12 and 13 modify the effective date for the provisions governing state-only MA funding payments for mental health services provided in children's residential facilities. And it extends the effective date for 2 months. And Section 14 extends the deadline for the Children's Mental Health Report until January 15th, 2019.
Article 4 is the opioids and prescription drug article. Section 1 is from House File 3024. This is dealing with prohibiting pharmacy gag clauses. So it provides that a contract cannot prohibit a pharmacist from informing a patient when the amount the patient is required to pay would be greater than the out-of-pocket costs. Section 2 is from House File 2987. This sets up the prescription drug repository program to provide donated drugs and related medical supplies. And that goes all the way to page 98. Then Section 3, this is House File 3024. This was language, I guess, amended on in modified form from House File 3012. And this basically would prohibit a health plan company or PBM from requiring an individual to make a payment in an amount greater than the allowable cost. And the allowable cost is defined as either the co-payment amount or the out-of-pocket amount that would be paid if a health plan benefit was not used. Section 4 deals with limitations on the dispensing of prescription drugs. This provides that there is a 30-day limit to fill a prescription or to refill a prescription. Section 5 is from House File 3062. This directs DHS to establish a program to award grants to secondary school students and undergraduates to conduct opiate awareness and opiate abuse prevention activities. This language is modified from the bill that was heard in committee. The bill in committee was sort of contingent upon obtaining federal grant funding, and this delete all amendment provides funding for the program itself. Section 6 is from House File 3535. This directs the Commissioner of Health to provide grants to ambulance services to fund community paramedic teams to reduce opioid overdoses. And Section 7 is a repealer from the Drug Repository Bill, House File 2987. It repeals an existing cancer repository.
Mr. Chair and members, Article 5 is the Community Supports and Continuing Care article. Section 1 is from House File 3193 that creates a transition period when transitioning from day training and habilitation services to the new employment services under the disability waiver rate system. Section 2 is from House File 3139. This creates MA rates for the prescribed pediatric extended care centers. Section 3 is from House File 3251. This just changes terminology for the Home and Community-Based Services Innovation Pool. Sections 4 through 13 are all from House File 3191, which is the big disability waiver rate system bill that does several things. It creates a new competitive workforce factor. It removes the regional variance factor. It provides for some more robust reporting requirements. And it also changes the timing of the inflationary adjustments. If you're following along in the bill language, you can skip to page 125. Section 14 is from House File 4030, and that provides for a rate increase for a specific ICFDD facility. Section 15 is from House File 490. That provides for a nursing facility rate adjustment for a facility in Moorhead. Section 16 is from House File 3191, the DWRS bill, and this just removes some language related to some of the DWRS rate stuff. Section 17 is from House File 4206. That's the electronic visit verification bill. Modifies the electronic visit verification. Section 18 is new language. This is part of the DWRS package. It creates competitive workforce sustainability grants. Section 19 is from House File 3139. This is related to the prescribed pediatric extended care, and it just directs the commissioner to submit to the Federal Centers for Medicare and Medicaid Services any MA state plan amendments that are necessary. Section 20 is from House File 3451. This is related to the brain injury and CADI waivers, and it is allowing for service capacity to be transferred from one facility to 3. Section 21 is new. This is also related to the disability waiver rate system package, and this is just a direction to the commissioner related to submitting federal approval and setting out priorities for how that submittal should work. Sections 22 and 23 are from House File 4206. That's the electronic visit verification bill.
Mr. Chair and members, moving on to Article 6 of the bill. This is protections for older adults and vulnerable adults. All the provisions in this article were taken from House File 3308, the first engrossment, with the amendment that was adopted in the Finance Committee, and House File 3857. Section 1 amends the Healthcare Bill of Rights to allow patients and residents to exercise any of the rights in the Healthcare Bill of Rights free from restraint or coercion. Section 2 adds language requiring nursing homes to submit correction orders. Section 3 amends the Home Care Bill of Rights to provide that a person receiving home care services has the right to recommend changes in the services free from restraint or coercion. Section 4 amends home care statutes to require the Commissioner of Health to survey a temporary licensee within 90 days after the commissioner receives evidence that the licensee has begun providing home care services. Section 5 defined change in ownership survey for purposes of home care and requires these surveys to be conducted within 6 months after issuance of a new license due to a change in ownership. Section 6 establishes correction order requirements for home care providers. Section 7 amends the duties of the Director of the Office of Health Facility Complaints to specify that the Director has authority to issue correction orders and assess fines for all licensing violations or maltreatment determinations, including those identified as part of an appeal or review. Section 8 directs the Office of Health Facility Complaints to establish a safety and quality improvement technical panel. And Section 9 directs the establishment of a training and operations panel at the office. Section 10 establishes posting requirements for housing with service establishments regarding owners, managing agents, and persons authorized to accept service or process. Section 11 adds a cross-reference Section 12 establishes notice requirements as part of the Maltreatment of Vulnerable Adults Act to allow reporters to receive notice. Section 13 directs the Commissioners of Health and Human Services to develop written guidance materials for facilities and providers to help them with their comply with reporting requirements. Section 14 modifies biennial reporting requirements to the legislature by the Commissioner of Health and Commissioner of Human Services related to maltreatment. Section 15 modifies retaliation, language prohibiting retaliation against people who report maltreatment of a vulnerable adult. Section 16 requires the Safety and Quality Improvement Technical Panel to give a report and recommendations to the legislature on the listed information. Section 17 requires the Commissioner of Health to develop immediate penalties for serious violations of state law and submit those recommendations to the legislature. Section 18 establishes quarterly reporting requirements regarding the Office of Health Facility Complaints response to vulnerable adult maltreatment allegations. Section 19 establishes an assisted living and dementia care licensing working group. Section 20 establishes a dementia care certification working group. And Section 21 establishes an assisted living report card working group.
Mr. Chair and members, Article 7 is the Children and Families article. Sections 1 through 7 are all from House File 3778. It's the Child Care Assistance Bill that makes changes related to homeless families, transition year families. It modifies the frequency of the child care market rate survey, modifies the portability pool, and it modifies the maximum rates by setting them based off of the 2016 child care provider rate survey.
Section 8 of this section of this article removes the requirement for childcare providers to physically post a correction order, and that's from House File 3015. Section 9 is from House File 4094, and it allows those who teach training courses, childcare training courses, to count the hours spent conducting the training towards their annual training requirements.
Mr. Chair, Section 10 is from House File 3627. This is related to the homeless youth report, and it just exempts the commissioner from preparing this report in 2019 and instead requires the commissioner to update the 2007 report on homeless youth.
Section 11 is from House File 3133 as amended. It establishes grants for stable housing and support services for vulnerable youth, and also allows for program variances for certain programs that would like to serve a wider range of ages. It also requires the Commissioner of Human Services to consult with providers serving homeless youth, sex-trafficked youth, or sexually exploited youth, and make recommendations to resolve some conflicting requirements and to foster best practices. Section 12, it relates to House File 2996. That's the Child Welfare Training Academy bill. This section allows or requires that funds withheld from counties that do not meet certain child protection performance outcome thresholds be transferred to be used to support the Child Welfare Training Academy. Section 13 is from House File 2996. It requires that the commissioner partner with the University of Minnesota's MinLinks statewide data project to conduct a study on outcomes in the child welfare system. Sections 14 and 15 are from House File 3406 and modify certain provisions related to child support.
Mr. Chair, Section 16 is from House File 3627, and this relates to the homeless youth report and just requires the Commissioner of Human Services to update the 2007 legislative report on runaway and homeless youth, and lays out some guidelines for how the Commissioner should update that report and the information that should be included.
Section 17 is from House File 3246. It establishes a task force on childhood trauma-informed policy and practices. It lists who should be on the task force, how the task force will be staffed, the duties of the task force, and requires a report to the legislature, and also specifies that the task force expires after the report is submitted. Section 18 is from House File 2996. It requires that the Commissioner of Human Services modify the Child Welfare Training System and rename it as the Child Welfare Training Academy, and sets out the requirements for this new training academy, including that it will have 5 regional hubs with training targeted to the needs of each region. Section 19 is also from House File 2996. It's requiring the Commissioner to conduct a child welfare caseload study. And Section 20 allows the Commissioner of Human Services to make rules necessary to establish the Child Welfare Training Academy.
Mr. Chair, Section 21 is a reviser's instruction that just instructs the revisor to update terminology related to the Supplemental Nutrition Assistance Program. And Section 22 is from House File 3778. That's the Child Care Assistance Bill, and it's a contingent effective date that makes the changes to the CCAP program contingent on receipt of federal funding, and then also lays out priorities for implementing the changes that are in sections 1 through 7.
Mr. Chair and members, Article 8 is health licensing boards. Sections 1 and 2 and various other sections in this article are from House File 3367, which adds advanced practice registered nurses to various statutes, giving them the authority to engage in specific actions or certify or provide certain information. So Section 1 adds APRNs to a section related to public data. Section 2 modifies the Healthcare Bill of Rights by adding APRNs to those persons who may document that an activity is medically inadvisable. Section 3 is from House File 3101, and this authorizes the Board of Examiners for nursing home administrators to issue a health services executive license. Section 4 is also from House File 3367, and it adds APRNs to those who must receive notice and work to comply with the Healthcare Directive Act. Section 5, which starts on page 176 and goes until page 193, establishes and enacts the Nurse Licensure Compact. And Article 1 of this section of the Nurse Licensure Compact defines certain terms. Article 2 outlines general provisions and jurisdiction related to the compact. Article 3 outlines the requirements for applications for licensure in a state that's a party to a contract, or to the compact. Article 4 relates to additional authorities invested in state licensing boards in a party state. Article 5 establishes the Coordinated Licensure Information System and outlines requirements for the exchange of information through that system. Article 6 establishes the Interstate Commission of Nurse Licensure Compact Administrators. Article 7 establishes the rulemaking powers of the Interstate Commission. Article 8 outlines the oversight, dispute resolution, and enforcement provisions related to the compact. Article 9 establishes the effective date, how to withdraw from the compact, and how to amend and how the compact can be amended. And Article 10 deals with provisions related to construction and severability related to the compact. Section 6, which is on page 194. Just bear with me one second. Is also from House File 3848, the Nurse Licensure Compact. And it clarifies the applicability of the compact to existing nurse licensure laws in Minnesota. Section 7, also it specifies a definition of head of the nurse licensing board and authorizes the Board of Nursing to recover costs of investigating allegations against multi-state licensees. Section 8 on page 195 is from House File 4193, and this relates to Board of Optometry fees. Section 9 is from House File 4192, and it relates to Board of Social Work fees. Section 10, Sections 10, 11, 12, and 13 are all from House File 3571, the first engrossment. So Section 10 allows a pharmacist to accept a prescription drug order when not present in a pharmacy in certain specific emergency circumstances. Section 11 relates to the processing of those prescriptions in emergency circumstances. And Sections 12 and 13 relate to pharmacy licensure requirements, and Section 12 specifies that licensing requirements do not apply to manufacturers, wholesale drug distributors, or logistics providers who distribute home dialysis supplies and devices if they meet certain requirements. Section 13 provides an exception to a prohibition on licensed wholesale drug distributors for those distributing home dialysis supplies. Section 14 on page 202 is from House File 3640, the first engrossment. And so sections 14 to 19 are all from this bill and relate to the Health-Related Licensing Board background check updates and changes to the background checks. Section 18 relates to temporary license suspensions for health-related licensing boards. Skipping to Section 20, that is from House File 3023, the second engrossment. It requires continuing education credits on best practices in prescribing opioids and controlled substances, and it requires 2 credit hours within the current requirements for licensees with prescribing authority. Sections 21 to 27 are all from House File 3367, and they all add APRNs to various statutes. Section 28 is also from House File 3640, and it amends the chapter governing rehabilitation and employment of criminal offenders, and specifies that that chapter does not apply to licensing or registration for the health licensing boards. Section 29 is from House File 3195, and it establishes the Council of Health Boards work group to study and make recommendations on increasing access to telehealth clinical experience. And Section 30 is a repealer, and it repeals a section related to planning for health board criminal background checks, which is addressed in House File 3640.
Mr. Chair and members, Article 9 is the miscellaneous article, and that article begins on page 217 of the amendment. Sections 1, 2, and 3 are from House File 3543. Section 1 changes MNsure's operations funding. It lowers the premium withhold percentage that MNsure is authorized to retain from 3.5% to 2%. And it also limits, it caps the total amount that MNsure can collect in a year at 25% of the MCHA member assessment from 2012. Section 2 provides that a health plan that meets the minimum requirements in state and federal law for certification as a qualified health plan can receive such certification, and provides that MNsure is not authorized to establish additional certification requirements. Section 3 prohibits the Commissioner of Human Services from bearing insurance risk or entering into an agreement to pay claims for health coverage for a state health care program that's available for purchase through the MNsure website as an alternative to purchasing an individual health plan. Section 4 is from House File 3056, and it authorizes licensed physical therapists to provide a medical statement that can be used to obtain a disability parking permit or disability plates. Section 5 is from House File 3172. It amends the predatory offender registration statute to require the predatory offender notice of status required in that subdivision to be provided to licensed home care providers. Section 6 is from House File 3575. It establishes a Human Services Department restructuring working group. And Section 7 is from House File 3543. It requires health carriers when they're setting rates for individual health plans for calendar year 29 to take into account the lowering of the premium withhold percentage for MNsure. Article 10 is the Human Services Forecast Adjustments article, and Article 11 is the Appropriations article. And Mr. Chair, would you like me to go back to Article 1 at this time?
Yes, please.
Okay. Okay, so Article 1 begins on page 1 of the amendment. The first several sections are amendments to wells and boring statutes, and they are from House File 3824 and House File 3856. Section 1 amends the definition of boring to specify that it includes a temporary boring. Section 2 amends the definition of environmental well. Section 3 defines temporary boring for this chapter, Chapter 103I. Section 4 provides that a person is not required to notify the commissioner before constructing a temporary boring. Section 5 removes language that authorized a licensed plumber who does not have a well contractor's license to repair submersible pumps or water pipes if there is no licensed well contractor within 50 miles. Section 6 modifies the deadline for submitting a report to the Commissioner of Health relating to well or boring construction or sealing to within 90 days of completing the work rather than within 30 days. Section 7 amends a section on well notification fees. Section 8 amends requirements for notice to buyers regarding temporary borings. Section 9 prohibits a person from sealing a boring until a notification is filed with the commissioner, but exempts temporary borings that are less than 25 feet in depth from that notice requirement. Section 10 establishes requirements for notification regarding exploratory borings and establishes requirements for maps of those borings. And that completes the wells and borings portion of our bill. Section 11 establishes an advisory council on rare diseases, and this is from House File 2574. Section 12 establishes requirements for the Commissioner of Health to provide information about congenital CMV. And this is from House File 2653. Sections 13 and 14 establish requirements for the regulation of security screening systems by the Department of Health. Section 15 establishes an advisory council on pandas and PANs. Sections 16, 17, and 18 add alcohol and drug counselors to the Health Professional Education Rural Loan Forgiveness Program. Section 19 modifies the primary care residency grant program. Section 20 directs the Commissioner of Health to establish statewide tobacco cessation services. Section 21 makes a technical change based on a prior change made in another section. And then the next series of sections beginning with Section 22 are from House File 3240. These make a number of changes to home care statutes. And so those are 32 through 51. And the next section, Section 52, begins on page 43 of the amendment. Sections 52 and 53 direct the EMS Regulatory Board to adopt rules related to patient-assisted medication administration and standards for communicating with patients about the patient's need for emergency services. Sections 54 and 55 amend provisions that govern prescribed pediatric extended care centers. Section 54 amends the definition of medically complex or technologically dependent child. And Section 55 modifies licensing requirements for these centers. Section 56 directs the Commissioner of Health to distribute a grant to provide crisis telephone counseling services for people in suicidal crisis or emotional distress. Sections 57 and 58 allow the Commissioner of Health to award grants through the Eliminating Health Disparities Grant Program to decrease disparities in access to and utilization of high-quality prenatal care. Section 59 updates a cross-reference. And beginning with section 60, the next series of sections establish licensure requirements for speech-language pathology assistants. So that is section 60 through 76. Oh, I'm sorry, it's through 77. So then with section 78, which begins on page 61 of the amendment, sections 78 and 79 establish certification requirements for unlicensed personnel who can perform cremations. Section 80 is a phase-in section for licensure of PPEC prescribed pediatric extended care centers. Section 81 establishes an older adult isolation working group. Section 82 directs the Commissioner to adopt rules related to well and boring records. Section 83 directs the Commissioner to adopt rules related to regulation of security screening systems. Section 84 establishes requirements for the initial appointments and first meetings of the Advisory Council on Pandas and PANS. And sections 85 and 86 are a reviser's instruction and a repealer related to home care provider regulation. And I believe that completes the walkthrough.
All right, thank you, Ms. Floydquist. Is there any questions or clarifications on the walkthrough before we go to public testimony? All right, seeing none, thank you. And just so members know, the text has been out since last night. We're accepting amendments until 7 p.m. this evening for the bill. So that's the amendment deadline. And we do have a list of testifiers. And first up is Commissioner Johnson.
Thanks, ladies.
Welcome to the committee, Commissioner.
Thank you, Mr. Chair. Chuck Johnson. I serve as Acting Commissioner at the Department of Human Services. Thanks for the opportunity to comment on the bill today. I appreciate the amount of work that goes into putting a bill like this together and the amount of time that you all have spent on this session on focusing on issues to help people from Minnesota. We are pleased with some of the items that are included in the bill here. There are some of the federal requirements to the Child Care Assistance Program. We think those are important. We've been working at it for 3 years. Got some of them passed last year. Appreciate that you're trying to work on some of them this year. I know it's dependent on some federal money. We have been paying attention to that issue as well. There are a couple of issues that you have not addressed in the child care area that we're concerned about. One is tying the rate reimbursement to the 2018 market survey, not to the 2016 survey. And then also that this bill does not include the health and safety standards for the legal non-licensed child care providers, which is a provision of the federal requirements that we do need to be compliant with. So those are two issues we'd like to continue to try to work on. We're also pleased the committee has taken the changes that we've made to how we manage our chemical dependency treatment fund and some child support related changes that we think are common sense and will help us move forward. I also appreciate that the committee has taken some steps to try to address the DWRS issue. As you know, that was not an issue that the governor addressed in his own budget, but we are continuing to work with anyone here as well as with advocates and provider groups to ensure that if something does pass the legislature, that it does meet the federal requirements, that we don't run into the problems we had last year, and that also that it addresses the real workforce needs that we have amongst our disability providers in order to ensure that people get the services that they need. Also recognize the bill makes several investments to address the opioid crisis. This is one of the priorities from the governor. We would like to see some additional funding around the grants that we proposed in the DHS side of this, really to get local health, social services, and law enforcement to work together to address opioid crisis. We found that that's worked very well in certain communities. And we also are looking at a couple of items that would help to speed up access to treatment that we think could be part of this package. No, this is one that's going to be continuing work on over the next 5 weeks. Appreciate the opportunity to be part of that. The governor does continue to strongly believe that our efforts to help the people in the communities that are impacted by the opioid crisis should be funded through a stewardship fee on the pharmaceutical industry, and I believe that's an item that he will continue to advocate for. We also understand that as part of the governor's Safe School initiative, he included funding for the school-linked mental health grants. We understand that is actually in the House Education bill, so we appreciate that that's been addressed on that side of the ledger. We're disappointed that the bill doesn't address or fully address some of the other priorities the governor put on the table and has a few other items that we have concerns about or are opposed to. Specifically, the bill does not include the Minnesota Care buy-in. I would not say that's a surprise, but we do continue to believe this is a sensible option that we should have on the table as one of the alternatives for addressing both the costs and the reduced access to care that people are experiencing now in the individual market. We're also concerned that the elder care piece of the bill doesn't go far enough in terms of really addressing the concerns that have been raised by families who have been impacted by some of the issues within institutions across Minnesota. We appreciate this bill does include, from a DHS perspective, some partial funding for the Ombudsman for long-term care. We'd appreciate seeing the full request that the governor put forward. If we want to have a fully integrated system for reporting and managing abuse reports, we need to have a continued investment in the MARC system as well, the Minnesota Adult Reporting Center, and some IT improvements that go with that, and we think that's a piece that needs to be part of the puzzle. We also continue to believe that we need to move forward quickly to put a regulatory system in place for assisted living, and that is not included in this bill, and that a work group isn't an adequate response to the needs within that area. The bill also does not provide the governor's requested rate increase for personal care attendants. We have all heard the stories of people with disabilities who have been impacted by their inability to find a PCA and to get the help that they need to manage their daily living, to get to work, to do the things that they need to be part of the community. It's a modest request and a modest increase, and we hope the committee would consider it as we move forward. We continue to have concerns about the prescribed pediatric extended care center proposal, particularly around the policy side of segregating kids and whether that's the right direction to move. And then I think, as we've shared with this committee, some concerns around how the rate has been set within that service and needing to ensure that we have a rate that we can take to CMS and get approval on if we're going to expand that service in any manner. Also, as we discussed here last week, we don't believe the right path forward on premium reconciliation is to continue to move in that direction, and we have concern with that being included in this bill. We also have some concerns about fiscal issues related to how some of the technology funds for the department are handled within this bill. The bill includes a provision from House File 2725 that would essentially take the unexpended balances from the DHS Systems Fund and have the LAC provide approval around what happens with those dollars. Second, it takes $14 million that DHS had transferred to the Systems Fund specifically to support IT work within direct care and treatment, the creation of an electronic health record, which are woefully behind the rest of health systems on doing, as well as safety systems within our facilities across the state. And we believe those dollars are critical to helping us build out what we need to make direct care and treatment a safe and secure place to work. The flexibility we get by using our systems fund to fund our IT really helps us with managing large projects across years, also to manage the very complex flow of federal funds that we have to manage within our IT, both to manage the uncertainty and timing of those funding. And we would appreciate it if that could be something we manage ourselves going forward. We're still reviewing the bill, and I'm sure we'll continue to have feedback. I think we will probably provide a letter to the committee that will probably outline some of these concerns and perhaps more as we learn more about what's in here. As always, I'm available, my staff are available for technical assistance or any other help the committee may need. Thank you.
Thank you, Commissioner Johnson. Appreciate your testimony to the bill, and we will not hold you to your current list of concerns. Representative Murphy.
Thanks, Mr. Chair, and I just have one question for the commissioner, if that's okay. Commissioner, I, read through this proposal in the early hours of the day, and also had a brief conversation with you yesterday about the idea here embedded in the bill around preventing the 7% cut to the disability community. And I'm just wondering if you could, in a simple way, describe how this proposal would be implemented. Sometimes it's easier to hear it and understand it.
Commissioner Johnson.
Mr. Chair and Representative Murphy, I'm not actually the best person to do that. I'm sorry, and I'm wondering if I can call the audience and have someone else to help me with that. I know what the bill is intending to do, but I can't describe it very simply for you, unfortunately.
If that's okay, Mr. Chair, that would be great.
All right, Commissioner Johnson, whichever person you think is best able to answer that.
It's likely to be Ms. Hamilton. Thank you.
Welcome to the committee, Ms. Hamilton.
Thank you. Oh, shoot. I brought up the wrong piece of paper. Mr. Chair, members of the committee, my name is Heidi Hamilton. I'm with the Department of Human Services. From what I understand, I'm not the in-depth expert on DWRS, but from what I understand, we are, the bill is creating grants for providers to be able to access to transition to the new rates, or provide transition grants and provide competitive workforce grants to allow providers to maintain their rate as much as possible. I'm not exactly sure what the details are beyond that, but I can get more information too.
Thank you, Mr. Chair, and Ms. Hamilton. That would be awesome to get more information. And of course, I'll be talking with others as well, but this is an important part of the bill, an important part of the work of this session. So, I think for me at least, and I'm sure for others, it's going to be important to understand how this works and if it does work for the community. I appreciate your time.
Thank you, Representative Murphy.
Do you want any more details?
All right. Commissioner Malcolm.
Good afternoon, Mr. Chairman and members. Jan Malcolm, Commissioner, Minnesota Department of Health. Like Commissioner Johnson, I appreciate very much the opportunity to share some preliminary thoughts with you on this important bill. First, I want to thank this committee and you, Mr. Chair, personally, for recognizing the important role that public health and public health agencies play, including certainly the Minnesota Department of Health, in tackling some of our community's most challenging issues. Some of the things that are much in view today and much on your minds as they are on ours are things like elder abuse and the opioid epidemic. You've all heard the saying, an ounce of prevention is worth a pound of cure. And the more we know about the data on what drives health outcomes and what influences healthcare costs, the more true that saying rings to me. In fact, even the proportions are about right, I think, in terms of the influence on people's health and our ability to control healthcare costs down the road. And we do really genuinely appreciate the investments that this committee and this bill is making in public health. So I want to acknowledge that there is much in this bill that moves our common agenda forward. However, I am very concerned that almost none of the governor's budget priorities are included so far in the spending spreadsheet. The governor's budget proposal included difficult decisions and highly prioritized requests for spending to support and improve the health of Minnesotans in some particularly timely and critical areas. In respect for your time, I'll focus on just a few here. On the subject of vulnerable adult protection, which Commissioner Johnson addressed, As you know, the governor's proposal included some immediate, comprehensive, and really badly needed fixes to all aspects of the systems that are essential to prevent the abuse of elders and vulnerable adults in our state. Particularly notable, the governor's proposal really attempted to respond in a comprehensive way to all of the recommendations of the AARP-led Consumer Work Group, as well as to the recommendations of the Office of the Legislative Auditor, two important guidance documents that we have used to try to shape our policy and budget responses to this issue. While we appreciate very sincerely the time and the effort the House is spending on this issue this session, and while we do recognize that this bill continues the conversation about how to prevent elder abuse in our state, we don't believe it goes far enough, and we don't believe that it recognizes the important fact that there is strong bipartisan consensus for a more comprehensive and immediate response to this issue. We believe that there's a compelling case and an urgent need to respond in a more comprehensive way to this topic. For instance, the bill currently lacks the rather common sense, we think, proposals for electronic monitoring to enhance protections and security for residents and their families that, as I understand it, both the long-term care industry itself supports and the Senate has already agreed are needed. This bill currently lacks any real promise of action in law or regulation to stand up for elderly and vulnerable adults in assisted living settings or dementia care units. It lacks some of the basic civil rights enforcement protections that are necessary to ensure that our laws are more than just words on a page. We look forward to continuing to work with you over the coming weeks, with you, Mr. Chair, Representative Keel, who's leading on this issue, to build on this starting point, but to not stop at the current level of response. On the topic of safe drinking water, the governor's budget recommended increasing safe drinking water fees by 28 cents per connection per month. I will remind you that the safe drinking water fee has not been increased since 2005, and this very small increase is critically needed to allow MDH to maintain our proactive efforts to work with public water suppliers all over the state to ensure that Minnesotans enjoy safe drinking water, something we tend to take for granted but certainly should not. While the State Health Department provides these services currently to all public water supplies, this robust technical assistance that we are currently able to provide is especially vulnerable for smaller systems that lack their own resources and technical capacity, which leads them in the unfortunate position often of struggling to keep compliance with our standards. Without this modest funding increase, our state health department will have to reduce the services we provide to public water suppliers, and we'll need to make some tough decisions about how to allocate inadequate resources, which unfortunately could mean going to a more reactive rather than proactive model, waiting until a system is out of compliance and harm is being detected before we step in. On another topic, medical cannabis operations. The governor's budget included a realignment of the medical cannabis appropriation from current state government special revenue funds to spend the anticipated revenue that is already coming into this program and is projected to come in as the program continues its rather robust pace of growth. The appropriation would simply ensure consistent funding for our 24/7 patient registry database, for our expert staff who work hard to oversee the manufacturers of this medical cannabis program, and to staff an incredibly busy call center responding to the interests of Minnesotans and providers all over the state. This is a robust, clinically driven program that I have come to learn just in my short couple of months truly is a national model for a complex policy issue. And this budget adjustment does not change current law, nor does it raise fees. It has no fiscal impact on Minnesota taxpayers whatsoever. It simply would give us the revenues that already exist in the SGSR to be able to provide the service that Minnesotans rightly expect from us to administer this program under current law. Finally, I want to mention a policy issue that is contained in your bill about which the administration has some definite concerns. As the committee knows, the State Health Department is the lead agency for ensuring safety and quality in our healthcare delivery system. To that end, I want to remind you that Governor Dayton has opposed and vetoed the nurse licensure compact in the past, stating his view that the compact could compromise Minnesota's high-quality nursing standards by issuing an open invitation to any nurse practicing anywhere in the country, while ignoring our academic and clinical requirements. In closing, we're all rightly proud of the fact that Minnesota overall is a healthy state which faces many challenges underneath those averages and unacceptable disparities, which we all, I believe, are committed to working to reduce. Governor Dayton's budget proposal addressed a number of these most critical challenges in a strategic and effective way. His proposed investments would benefit the health of Minnesotans today and into the future. I pledge to continue to work with you over the coming weeks to improve upon this budget proposal as we go through the next phases of this process. I thank you for your work to date and look forward to continued conversations. Thank you, Mr. Chair.
Thank you, Commissioner, for coming today, for your testimony, and also for your work particularly in the area of elder abuse and reporting. You had three things that you kind of started off with elder abuse, electronic monitoring, number one, civil rights, number three. And the middle one, I kind of didn't understand the issue around that. If you could just clarify what your second point was, please, because I just didn't understand.
Thank you for the opportunity, Mr. Chair. As Commissioner Johnson addressed this as well, this is specifically the concern that we believe we need to move now toward creating a licensure framework for assisted living and dementia care. That we've been discussing this issue for many years, and that rather than have a task force to discuss whether we need to fill in a regulatory gap in our long-term care system, that the governor has proposed getting the policy framework enacted in this session of the legislature to allow us to convene a work group to do the detailed implementation planning for a licensure framework for assisted living and dementia care units in specific.
Okay, Commissioner, I guess I think the second piece is I had you stand up for seniors and their issues around that. Were you speaking to protect safety and protection of seniors who live in assisted living facilities through licensure and some sort of monitoring, inspections, so forth?
Thank you, Mr. Chairman. Yes, and my point was that the governor believes, and we believe strongly, that a part of responding to the problems that we've all learned about in the elder care system is to fill in what has become a failure of our regulatory framework to keep pace with the evolutions in the long-term care industry through a licensure framework.
All right, got it. Thank you.
Thank you.
Thank you. Appreciate that. Other questions for Commissioner Malcolm? Seeing none, thank you for coming.
Thank you for your time.
Mr. Flanders, welcome to the committee. Please introduce yourself and proceed.
Thank you, Mr. Chair and members of the committee. My name is Matt Flanders, and I'm the legislative specialist at Citizens Council for Health Freedom. I'd like to share just a few things that we appreciate the bill and then a few concerns that we have. We do appreciate the language on page 90 that prohibits health plans and PBMs from contractually prohibiting a pharmacist from informing a patient of a price differential. And we also appreciate the language on page 98 requiring a health plan or PBM to allow an individual to purchase at the lowest cost. Both of these provisions benefit patients. We are happy to see the reduction in the tax on premiums in the individual market that fund MNsure on page 217. And regarding appropriations, we appreciate that this bill does not include money for a Minnesota Care buy-in, and we are glad the bill maintains the sunset of the provider tax. Regarding concerns we have on page 88, the mental health screenings for inmates. We do not necessarily oppose the sharing of this data in this section, but we would like to see consent for the sharing of an inmate's information after they are released. On page 99, the opioid dispensing limitations. We do not support restricting a physician's or prescriber's medical judgment to prescribe medication as he or she sees fit. And on pages 45 through 46, and in the appropriations on 235, we have concerns with how this money will be spent. We have long had concerns with the $2 million appropriated for infant mortality and how that money has been spent by the department. We've also struggled to find the annual reports required in 145.928 that are required to disclose how the money is spent. So we do appreciate a number of these pieces in this bill. We have some concerns and appreciate you giving me the time to share them with this committee.
Thank you, Mr. Flanders. Next up, we have Sarah Grafstrom, and on deck, Jonathan Watson. Welcome to the committee.
Thank you, Mr. Chair and members of the committee. My name is Sarah Grafstrom, Director of Government Relations for ARM, representing our nearly 140 provider organizations and their nearly 100,000 employees who provide home and community-based services to individuals with disabilities across the state. I'm here today to say thank you for recognizing the potential devastating impacts of a 7% cut to disability service rates and for funding the Best Life Alliance legislation to stop the cut by creating a competitive workforce factor and moving the inflationary adjustment from every 5 years to every 2 years. We believe these important changes will help us work towards a long-term sustainability in our system. Since 2013, our members have reported overtime cost growth of 80%, with turnover rates of 38 to 40%. It's important to note that within those turnover rates, 60% is from employees that have been in their job for less than a year. With over 9,000 direct support professional job openings across the state, we are in the midst of a workforce crisis and simply would not be able to sustain a 7% cut. We look forward to continue to work with this committee on finding new and innovative ways to provide quality services for people with disabilities. And again, want to say thank you for working to stop the 7% cut.
Thank you for your testimony. Oh, I'm sorry. Representative Liebling has a question for you, Ms. Grafstrom.
Yeah, hi, thank you, Mr. Chair. One question that I've had as I've reviewed the bill is in the DWRS section, one of the things it's doing is removing a regional variance factor. And I don't remember if we had any sort of discussion about that in committee, and I'm wondering if you can explain why that's happening. Because from what I understand, the regional variance factor is basically a weighing to account for how much the cost of care is in different parts of the state. Obviously, you know, wages are different and the cost of getting a house is different in different places. And that's being completely removed in the bill, creating some winners and losers. Why is that being done?
Ms. Grafstrom.
Thank you, Mr. Chair and Representative Liebling. And if it's okay with you, I would like to phone a friend. Our senior policy director at ARM can come explain the regional variance factor in more detail.
Welcome to the committee, Ms. Turner.
Thank you, Mr. Chair. I'm Barb Turner, Senior Director of External Affairs at ARM. And the reason the regional variance factor came out it initially came out because of some other work we were doing with the bill. And as it progressed, we left that change out. One of the primary reasons is because of how the factor is figured, different counties go in and out of regions based on, I don't know how that happens, but they're, so for example, Mille Lacs County is currently in the metro region. But next time they do the adjustment, it may not be. And so it's because of a real instability for providers because of some of how that works. And in working with the providers who are impacted by that, we came to an agreement that the good things in the bill outweighed the bad, kind of the negativity of that for some members, especially with the adjustment of every 2-year inflationary adjustments. And so that's why it ended where it ended right now.
Representative Liebling.
Thank you, Mr. Chair. Well, that is, we probably requires a lot more discussion than what we are able to do right here, right now. But so you're essentially saying that the losers under the bill, the people who are in more expensive areas, like, for example, Rochester, where it's really hard to get providers because of because costs are higher and because of competition from some rather large businesses that can pay a lot more for the same employees, that the people who are providing the services who stand to lose from the removal of this rate factor are okay with it? Your members who are losing under this removal are okay with that?
Senator, our Representative Liebling, Chair, we make decisions based on representation from our board, and we have representatives on our board from all of the areas, metro and non-metro. And again, we come to a consensus of what is kind of greater good for all. And so there is an acceptance that sometimes we take. Not everyone gets everything they want, but that's where we ended up with the coalition bill as it sits right now.
Representative Considine.
Thank you, Mr. Chair. Safe to say, though, that the biggest loser is the fact that there are no wage increases for PCAs and home health care folks again this year. Correct?
Ms. Grafton.
Chair Dean and Representative Considine, we agree. We wish we were here fighting for increased rates instead of keeping the rates that we have fought for the past 4 years.
Me too.
Thank you. Yes, this will, Mr. Chair, yeah. Yeah, thank you. Yes, this is Mark's, we've heard it 3 times in this committee this session, and we've gotten 0 movement on it. Thank you.
Thank you, Ms. Grafton. Next up, Mr. Watson. Welcome to the committee.
Thank you, Mr. Chair, members of the committee. My name is Jonathan Watson. I'm the CEO of the Minnesota Association of Community Health Centers, represent the state's 17 federally qualified health centers, or FQHCs. I'm here today to support 2 main provisions of the amendment here today. The first one being the streamlining of Medicaid payments to health centers. This is in Article 2, Section 4 on page 73. And this does improve the reimbursement process for FQHCs for the Medicaid patients that we serve. We would simply submit our claims directly to DHS for payment. And what this effectively does is it frees up some administrative resources we currently deploy to chase claims, frankly, is in terms of getting paid under the medical assistance program. And it allows us to really eliminate, we have to resubmit claims at times too. So this really does bring down the administrative costs for the health centers. We're going to redeploy those dollars to the needs of our communities, which range from the crisis in the opioid in our communities, along with dental access as well. That's a very troubling issue, and particularly in greater Minnesota. The second piece I do want to talk about too is in Article 2, Section 5, which is we're going to work with the Department of Human Services to bring forth a recommendation back to all of you next March on how we can share in the 340B savings that program does generate for prescription drugs. Congress did provide the authority for FQHCs to draw down some of these savings. Unfortunately, it didn't tell us how to do that. So we're going to work with the Department of Human Services over the interim and hopefully join the 12 other states that have figured it out for their FQHCs so they can, again, reinvest into some of their programming to expand access to care throughout the state. I would like to point out that the cost of these 2 proposals is about $21,000, but the return on investment for all of you is incredible in terms of the additional services we're going to be providing to all of our patients, whether they're uninsured or on medical assistance. I would like to thank Representative Zerwas for including this and Representative Dean for including in this proposal as well. The other 2 provisions I'd just like to note very quickly that I support, that our association supports, is the $613 investment in grants from the Minnesota Department of Health for prenatal care disparities. This is an important investment that Representative Pinto brought to the legislature this session. Community health centers serve about 3,000, provide 3,000 patients with prenatal care, and roughly 90% of these patients are from communities of color. So we're seeing the disparities on the front lines as well. And then lastly, under Article 4, the opioid section and Section 5, Representative Dean, your legislation for the prevention and grant for the kids in ages or grades 7 through 12 and undergraduates for public awareness of opioids. The community health centers are mentioned as a community partner, and we appreciate that because we are truly on the front lines of fighting that crisis. So again, thank you for including those 2 provisions for the FQHC specifically, and thank you for all your work, and I can stand for any questions. Thank you.
Thank you, Mr. Watson. Representative Liebling.
Thanks, Mr. Chair, Mr. Watson. I just wanted to note, when I went through the bill and the part that you just referenced about the prenatal care, about the grants to reduce disparities in birth rates and so on, or health and birth weights.
Right.
The current language in the bill sets out a goal for reducing disparities by 50% by 2010. That's in current law. Pretty sad. So I don't know if we, obviously that it's kind of an embarrassment to have that in law, but even worse is that we are so far behind in meeting that goal. So thanks.
And Mr. Chair, Representative Ling, just to put some more onto that, we do break down the low birth weight rates by race and ethnicity at the community health centers. And of 3 of the 5 race and ethnicities, the community health centers actually outperformed statewide averages. And so there's some learnings from the FQHCs that we can expand statewide. And it's really impressive and remarkable that that happens given our patient profile, the poverty, the language, and the insurance status. So we're glad to keep participating in those.
Thank you, Mr. Watson.
Thank you.
Next up, we have Sue Abderholden and Jessica Anderson on deck. Welcome to the committee, Ms. Abderholden.
Thank you, Mr. Chairman. Members, Sue Abderholden, Executive Director of NAMI, Minnesota. So first, I really want to thank you for including the 2 months for the children's residential treatment so that we don't run out of money before the end of the biennium, and extending the date of the report so we can come back with some real recommendations to make sure we can figure out what to do with our entire children's mental health residential treatment programs. We support the task force on childhood trauma. We know that this is actually a huge issue. We need to have all the different systems involved, whether it's housing, juvenile justice, health and human services. And I think if we can all work together to really figure out how we identify and prevent adverse childhood experiences, that pays off in the long run. We support actually allowing the jails to share information so that they can connect people to services and that we can hopefully reduce recidivism, particularly among people with mental illnesses. And while the money is actually in the education bill, we really do support, as you know, School Linked. We do think that we don't need a pilot for telemedicine. We already know how to do that. It's really making sure that we can use those funds to buy the information technology needed. And we support including the suicide prevention dollars. I will say that we came in with not, we lowered our expectations coming into this legislative session, just knowing that it was a supplemental year. But there were just a couple things that I just wanted to mention. Supportive housing is one of those things that really reduces hospitalizations, particularly for people with serious mental illnesses. They don't want to live in corporate foster care settings. They want their own place, but they need the supports on site to be able to do well. The other thing is there's been a lot of talk about, opioids, but one thing that's really been missing is that the last research report I saw just last week is that 50% of the people who are addicted to opioids have an underlying mental illness, typically depression and anxiety, but we've not talked at all about integrated dual diagnosis treatment and how to address that. I will say that my biggest disappointment and something that was really a priority for us is the language that would have really moved our state forward to begin enforcing mental health parity. We wanted to create, as you know, the bill got down to a small task force to figure out together how health plans can report the information to Commerce and Health to demonstrate compliance. I've continued to work, even last night, on amendments to the language to really bring down that fiscal note so that it should be getting next to nothing. We'll do writing, we'll do whatever we need to do to kind of get this forward. But in order to really continue to build our mental health system, we need private and public health insurance at the table, paying for people's care and treatment. But thank you very much.
Thank you, Ms. Abderholden. Jessica Anderson, welcome to the committee.
Thank you, Mr. Chair and members. My name is Jessica Anderson. I'm the Legislative Affairs Director for Children's Defense Fund Minnesota. We express our appreciation for including policies in this bill that stand to help children facing a steeper ladder to success, including, for example, the Task Force on Childhood Trauma, the Child Welfare Training Academy, and the studies on child welfare caseload, and also the outcomes of children in the child welfare system. Similarly, given our state's child care challenges, we thank you for including needed reforms to the Child Care Assistance Program. These will bring greater stability to the lives of children, parents, and providers to the benefit of our communities and state. And we appreciate Representative Roz Peterson's leadership on this topic. However, as the commissioner kind of alluded to, in order to be in federal compliance and ensure the CCAP provider reimbursement rate doesn't erode year after year, we encourage lawmakers to support tying that rate to the most recent child care market rate survey on an ongoing basis rather than just to the 2016 survey. This would require a state investment in addition to the federal funds that are used in this bill, and we encourage you to make that change in the final budget agreement. So now I'll turn briefly to a few concerns we have with the bill. First, we oppose trying to collect those incorrectly billed premiums from Minnesota Care recipients, just given the effect it could have on low-income families' ability to meet basic needs. Second, we oppose reducing the MNsure budget, where we've created a one-stop shop healthcare access system and infrastructure. And third, we oppose discontinuing or not continuing the provider tax, which helps to fund important healthcare programs that increase access to care while decreasing uncompensated care costs to providers across Minnesota. Thank you for your time and for allowing me to testify.
Thank you for coming. Next up, we have Commissioner Higgins. Welcome to the committee.
Thank you, Mr. Chair. I feel like a bad penny. I keep showing up at your committee.
Oh, we're always happy to have you.
Thank you. I'm Hennepin County Commissioner Linda Higgins. I'm here today on behalf of the Association of Minnesota Counties, where I serve as the chair of the Human Services Policy Committee. First, I want to say thank you for your work on this bill. It includes provisions that will be helpful to counties to reduce child care waiting lists and create additional foster care placements. These provisions help us better serve children and families, and we appreciate your partnership in working with us to accomplish those goals. We recognize there are many competing priorities in health and human services. Across the state, there are significant needs, one being child protection. We appreciate the committee's recognition of the growing need for improvement in the child protection system through the creation of the Child Welfare Training Academy. We applaud this committee's goal of strengthening the training of staff statewide, but we have serious concerns about how the initiative is funded. In Article 7, Section 12, the funding withheld from counties that don't meet the performance measurements would be transferred to fund this new academy. While the training is needed, the proposal to fund it at the expense of the frontline services isn't the answer. We can't improve the child protection system by taking away needed funds. We can't expect performance quality to improve when reports of child maltreatment have doubled and funding is already not keeping pace. We believe the funding designated for counties should be used to increase the staffing to reduce the caseloads, and we'd support eliminating the withholds altogether. This would help counties struggling to lower caseloads to reach benchmarks. In this sensitive area where children are at risk, we simply cannot be expected to do more with less. However, we do want to partner with you to work on improving the system. A budget-neutral provision supported by counties was not included in this bill, and that's the child well-being model. Child well-being would help counties to continue to make progress in the area of child protection. We would love to see that included as you mark up this bill. This provision would allow counties from across the state and DHS to work together to identify improvements that could be made in the system to prevent maltreatment and to achieve permanency for children, which is another common goal. We look forward to continued conversations with you on these and other important topics, and thank you again for all the work that you do.
Thank you, Commissioner. Pam Selvig?
Good afternoon,
Welcome.
Mr. Chair, members of the committee. Thank you. My name is Pam Selvig, and I am the Health and Human Services Director with Scott County. I am actually here today on behalf of MICA, the Minnesota Intercounty Association. Want to thank you for including several issues that are helpful to counties. Last year, legislation passed that allowed for care coordination to focus on individuals who had been detained by law enforcement, who historically would have been incarcerated, but would be better served through community-based interventions for their chemical and mental health needs. DHS is now in the process of completing the waiver request. In doing so, it was agreed that a few language changes were needed to clean up last year's legislation. The language adds alcohol and drug counselor as well as a recovering peer working under the supervision of an alcohol and drug counselor to the list of professionals who can provide care coordination. It also provides legislation to include Native American tribes' ability to provide the service. The language was agreed to by all of the stakeholders, and we appreciate you including it. From a public health perspective, we appreciate the inclusion of the exemption to the MA limit to telemedicine services for the treatment and control of tuberculosis. Because treatment protocols for TB can take many months, this will help our local public health departments to better manage services for people afflicted with this disease. Project Legacy, located in Olmsted County, was founded 10 years ago to provide intensive support and opportunities to youth of color living in generational poverty. It has evolved from a grassroots program serving a handful of youth to what today is one of the largest programs in Rochester, serving a population that is underserved by other programs. In partnership with Olmsted County Social Services, Workforce Development Incorporated, Community Corrections, and the business community, Project Legacy provides intensive long-term supports, including educational assistance, food, shelter, clothing, medical and dental care, and chemical dependency counseling. Untreated trauma is addressed through group therapy that is co-facilitated by Mayo doctors. More than 100 youth are currently being served. One-third of these youth are actually attending college. Finally, I just want to mention that we have had good conversations regarding reducing the county cost share when a client no longer meets hospitalization criteria at the Anoka Metro Regional Treatment Center and the community-based behavioral health hospitals. We look forward to continuing that discussion. With that, I want to thank you for your time.
All right, thank you for your testimony, and that will complete the testimony that we have time for this period. We're going to have to come back this evening, and we will be back in this room at room 10 at 6:30. At the call of the chair. Watch your emails for anything different, but probably 80% chance 6:30. All right, we are in recess.